Now, let's begin with the respiratory tract and its defenses. The respiratory tract is the most common way for infectious agents to enter and gain access to our body. Since we are breathing 24 hours a day, everything that is in the air we breathe passes at least temporarily into this organ system. The respiratory system is divided into two parts, the upper and the lower respiratory tracts. The upper respiratory tract includes the mouth, the nose, the nasal cavity and sinuses above it, the throat or pharynx, and the epiglottis and larynx. The lower respiratory tract begins with the trachea, which feeds into the bronchi and bronchioles in the lungs. Attached to the bronchioles are small balloon-like structures called alveoli, which inflates and deflates with inhalation and exhalation. There are features of respiratory system that protects it from infection. For example, the nasal hair to trap foreign particles, cilia on the epithelium of the trachea, and bronchi or ciliary escalator that propel the particles upward and out of the respiratory tract. Mucus on the surface of mucous membranes lining the respiratory tract serves as a natural trap for invading microorganisms. Once the microorganisms are trapped, involuntary responses such as coughing, sneezing, and swallowing can move them out of the sensitive areas. These are the first line defense. The second and third lines of defense also help protect the respiratory tract. Macrophages inhabit the alveoli of the lungs and the cluster of lymphoid tissues or tonsils in the throat. Secretory IgA against specific pathogens can be found in the mucous secretions as well. Let's proceed with the normal biota that can be found in the respiratory tract. Due to the constant contact with the external environment, the respiratory serves as a home for large numbers of commensal microorganisms. There are 9 major genera that belongs to the normal biota of the respiratory system. These are Prevotella, Sphigomonas, Pseudomonas, Acinetobacter, Fusobacterium, Megasphaera, Veillonella, Staphylococcus, and Streptococcus. Yeast such as Candida albicans can also be found in the mucosal surface of the mouth. Note that some of the bacteria considered as normal biota in the respiratory tract can cause serious disease, especially in immunocompromised individuals, and these are Streptococcus pyogenes, Haemophilus influenzae, Streptococcus pneumoniae, Neisseria meningitidis, and Staphylococcus aureus. Not all microbes that are part of the normal biota causes disease. There are microbes that reduces the chances of pathogens to establish themselves in the same area by competing for space and resources. For example, Lactobacillus sakei, a sinus microbiome that can suppress the pathogenic potential of another normal biota organism, and the Corynebacterium tuberculosteriacum, which can reduce the incidence of sinus infection. To summarize, here is a table of respiratory system defenses and normal biota. For the upper respiratory tract, the defenses are nasal hair, ciliary escalator, mucus, involuntary responses such as coughing and sneezing, and secretory IgA. The normal biota that can be found in the upper respiratory tracts are Moraxella, non-hemolytic and alpha-hemolytic streptococci, Corynebacterium and other diphtheroids, Candida albicans. Note that Streptococcus pyogenes, Streptococcus pneumoniae, Haemophilus influenzae, Neisseria meningitidis, and Staphylococcus aureus are often presented as normal biota. For the lower respiratory tract, the defenses are mucus, alveolar macrophages, and secretory IgA, and there are no normal biotas that can be found in the lower respiratory tract. Now let's talk about the upper respiratory tract diseases caused by microorganisms. Common cold. often called as rhinitis from the Latin word rhin meaning nose and the suffix itis meaning inflammation. The signs and symptoms are sneezing, scratchy throat, runny nose or rhinorrhea. It usually begins 2 or 3 days after infection. It is not accompanied by fever, although children may experience low fever not higher than 102 degrees Fahrenheit. The causative agents are rhinovirus, coronavirus, adenovirus, and respiratory syncytial virus or RSV. Pathogenesis and virulence factors. The virus that induces a common cold must penetrate the mucus and find a firm attachment. Once they are attached, they use the host cells to produce more copies of themselves. The symptoms we experience is the result of our body defense against viral invaders. Virus-infected cells release chemicals that attract cytokines and inflammatory mediators. Transmission and epidemiology. It is transmitted by a droplet contact. Some cases, virus can be airborne in droplet nuclei and aerosols. Practically, everybody gets cold fairly frequent. Prevention. So far, there is no vaccine for the common cold. The best prevention is to stop transmission between the hosts by frequent hand washing and to avoid droplets from traveling away. Cover mouth and nose when sneezing or coughing. Treatment. There is no chemotherapeutic agents that can cure colds. Over-the-counter agents such as antihistamines and decongestants may help ease the common cold. Zinc may appear to block the replication of the rhinovirus. Sinusitis. Commonly called a sinus infection, this inflammatory condition of any of the 4 pairs of sinuses in the skull actually can be caused by allergy, infection, or simply structural problem such as narrow passageways or deviated nasal septum. The signs and symptoms are nasal congestion, pressure above the nose or in the forehead, feeling of headache or toothache, facial swelling or tenderness, and discharge from mouth and nose appears opaque. The causative agents can be virus, a bacteria, or a fungi. The most common mode of transmission for virus is direct or indirect contact, and for various bacteria, endogenous opportunism. For various fungi, introduction by trauma or opportunistic overgrowth. The culture and diagnosis. For virus, culture is not usually performed. Diagnosis is based on clinical presentation. For bacteria, culture is not usually performed. Diagnosis based on clinical presentation, occasionally on X-rays or other imaging technique is used. For various fungi, it is the same as various bacteria. To prevent virus infection for common cold, observe proper hygiene. There is no treatment for virus. Broad spectrum of antibiotics will do for various bacteria. For various fungi, physical removal of fungus in severe cases until fungal is used. Distinctive features of virus. Viral and bacteria are much more common than fungal infection. For bacteria, same as the virus. And for various fungi, suspect in immunocompromised patient. Acute otitis media. This condition is another common sequence of rhinitis or the common cold, and for reasons similar to the ones described for sinusitis. Viral infections of the upper respiratory tract lead to inflammation of the eustachian tube and the buildup of fluids in the middle ear. which can lead to bacterial multiplication in those fluids. Although the middle ear normally has no biota, bacteria can migrate along the eustachian tube from the upper respiratory tract. When bacteria encounter mucus and fluid buildup in the middle ear, they multiply rapidly. Their presence increases the inflammatory response, leading to pus production and continued fluid secretion. The fluid is referred to as effusion. The signs and symptoms are fullness or pain in the ear, loss of hearing. Severe or untreated infections can lead to ruptured eardrum because of pressure of pus buildup or internal breakthrough of the infected fluids, and can lead to meningitis or mastoiditis or intracranial abscess. The causative agents are Streptococcus pneumoniae, Haemophilus influenzae, mixed infection with virus and bacteria. Here is a picture of a case of otis media. The most common mode of transmission is endogenous. The virulence factor for Streptococcus pneumoniae is capsule hemolysin. For Haemophilus influenzae is capsule fibrae. Culture and diagnosis usually rely on clinical symptoms and failure to resolve within 72 hours. The prevention for Streptococcus pneumoniae is pneumococcal conjugate vaccine. For Haemophilus influenzae is HIB vaccine. Treatment: wait for resolution if needed, amoxicillin or amoxicillin plus clavulinate or cefuroxime. Same for as pneumoniae for Haemophilus influenzae, and for other bacteria or virus, wait for resolution. If needed, a broad-spectrum antibiotic, azithromycin, might be used in absence of etiologic diagnosis. Distinctive features: for other bacteria or virus, suspect if fully vaccinated against other two. Pharyngitis. This is an inflammation of the throat which the host experiences as pain and swelling. The severity of pain can range from moderate to severe depending on the causative agent. Signs and symptoms: viral sore throats are generally mild and sometimes lead to hoarseness. Sore throat caused by group A streptococci are generally more painful than virus, accompanied by headache, fever, and nausea. Reddened mucosa, swollen tonsils, white products of inflammation are visible on the walls of the throat. Swollen mucous membrane, foul-smelling breath. 2 to 5 days of incubation period for most sore throats. Causative agents: most commonly caused by the same virus causing common colds, the result of mechanical irritation from prolonged shouting or from drainage of an infected sinus cavity. Streptococcus pyogenes and Fusobacterium necrophorum. Pathogenesis: scarlet fever is the result of infection with an S. pyogene strain that itself infected with a bacteriophage. Rheumatic fever is thought to be due to an immunologic cross-reaction between the streptococcal M protein and heart muscle. It tends to occur approximately 3 weeks after pharyngitis has subsided. Glomerulonephritis is thought to be the result of streptococcal proteins participating in the formation of antigen-antibody complexes, which then are deposited in the basement membrane of the glomeruli of kidney. It is characterized by nephritis, blood in the urine, increased blood pressure, and occasionally heart failure. Virulence factor: for S. pyogenes, lipothoic acid or LTA, M protein, hyaluronic acid or HA, streptolysine O or SLO, streptolysine S or SLS, and superantigens. For F. necrophorum, endotoxin and leukotoxin.
Transmission and epidemiology. Most SPI genes are transmitted by respiratory droplets or direct contact to mucus. F. necrophorum is an opportunistic bacteria. Viral pharyngitis can be acquired by all forms of contact. Culture and diagnosis. For SPI genes, beta-hemolytic on blood agar, sensitive to bacitracin, and rapid antigen test. For F. necrophorum, it glows on anaerobic agar. Virus. Goal is to rule out SPI genes. Further diagnosis is usually not performed. Prevention. No vaccine exists for group A streptococci. To prevent the infection, observe proper hygiene. Treatment for SPI genes is penicillin, cephalexin in penicillin allergic. For necrophorum, penicillin or cefuroxime. And for virus, symptom relief only. Diphtheria. For hundreds of years, diphtheria was a significant cause of morbidity and mortality. But in the last 50 years, both the number of cases of the fatality rate have steadily declined throughout the world. Signs and symptoms. Sore throat, lack of appetite, low-grade fever, pseudomembrane forms on tonsils or pharynx. Exotoxin manufactured by the bacterium may penetrate the bloodstream and travel throughout the body. Causative agents. Corynebacterium diphtheriae. Pathogenesis and virulence factors. AB toxin is an exotoxin that is encoded by a bacteriophage of C. diphtheriae. ADP ribosylation. The release of diphtheria toxin in the blood lead to complication in distant organs, especially myocarditis and neuritis. Culture and diagnosis. In tellurite medium, they appear gray or black colonies. They are club-shaped on gram stains. Treatment begun before definitive identification. Prevention treatment. Diphtheria toxoid vaccine, part of DTaP. Antitoxin plus penicillin or erythromycin. Bed rest. Heart medication. Tracheostomy or bronchoscopy to remove the membrane.